Thank you so very much. Good morning, everyone. It's such a pleasure to be on Hornet this morning. I've never been on Hornet before, so that's great for me. I'm going to be talking, as we've mentioned, what do? I press on this? No, I press on the big one. Yes, what I plan to cover, this is what Gus said I should cover, which is a lot. But basically, I have to look at the evidence, the public health evidence around the effects of PrEP. And of course, that's important. What's also tricky is I haven't got my mics right. Okay, no. What's also tricky is that not a lot of countries are providing that evidence. So there's probably more evidence out there than there is published, and I'll be focusing more on the published. And then we'll look at how that all works together. It's not just about PrEP, as we've said, and there's a lot more to it. So first of all, a little question to the audience. Can we end HIV in our lifetime? Just put up your hands if you think this is possible in our lifetime. Whatever your definition of lifetime is, it's not important, okay? Some of us have got shorter lifetimes than ever. I don't know, that's about a third of people. Keep your hand up there if you think, it's not just, okay, can we, theoretically, can we? And keep it up there if you think we actually will. Keep it up. Oh, it's going down.
It depends on your definition of end.
Yes, of course, all of that. Thank you for the all budding epidemiologist. It's a theoretical question. And then one more question, is PrEP the solution we've been waiting for? Put your hand up if you think that is. Oh. So we've got quite a few half-glass empty people. And now I'll bear that in mind with my presentation. I need to gear that up. Okay, so I'm going to start with the take-home messages because even if I talk too fast in the end, you'll have them here now. Okay, so firstly, yes, PrEP is working. We know all that. There's lots of efficacy studies, and I'll show some other. It's cost-effective. We're going to have a talk about cost-effectiveness that follows. It can be scaled up relatively quickly. We've heard about that, but actually it's not happening, and that's what Tamoor's just presented. And it has a very big contribution to make in the whole scheme of HIV elimination agenda. But that depends on so many things, which we've heard about already, and I'll cover those. And really, unless it's part of a combination prevention program, and it's led by community, then it's not going to work. And I think that's the key message to take with you. So the rest I can go very fast. Here we go. Okay, is it working in the real world? Well, efficacy versus effectiveness. Now you all know efficacy is about whether it works in the test tube. Yes, it does. It works in the test tube. Does it work in the real world? Does it work in the test tube for men? Absolutely. And we heard yesterday from Sindra, it's not necessarily sure that it's working for women and all other groups. So we need to do much more better research and involve other groups. So the answers to is it working, its efficacy in the test tube is still not even totally resolved. And of course, we are getting new drugs and new formulations that we need to keep doing. And I've got a quote there from, in fact, AVAC around the urging of regulators to involve all populations and women in this case. So what modelling tells us when we look at it, and we'll have a whole discussion, a whole session, so I'm not going to go too much into it, but the point is the models do tell us that it's cost effective, and it does depend on a number of things, of course. How much the cost, we saw the variation in country A at 800 per month for the cost of the drug. It must be quite a lot less cost effective at the moment if you're paying that much, so you probably want to be negotiating your prices. But the point is, in the long term, even if we look at non-generics or generics and we look at the whole cost of the system, a lot of the models have shown that there is a cost effectiveness over a long period. I won't say any more than that because we've got a talk coming. But it's all about combination prevention. And again, here's a nice definition from AVAC that I've stolen because I think it really says the essence of why we're here today. It's about really finding and delivering at scale what works. And it means that some things are going to have to stop and improve, other things have to get up to scale, and it's a combination of these things They have to be evidence-based, and they certainly have to ensure the community at that local level is getting what they need. And it's not the same formula for everybody everywhere else. So they're my taking-home messages. Now, some of the models here, you can see averted infections. That's how a lot of the models will show you. One of my pleas would be for this conference, can we create a very basic cost-effectiveness model that we could do in different countries? So with our own numbers and with our own. So that would be a simple model that we could use for politics within each country. Maybe we can, maybe we can't. Maybe David can answer that during his talk. A bit unfair, I'm sorry. Population level effectiveness is the issue of what I'm talking about mostly here today, though. And it's about whether or not, even though it works in their test tube, is it working at a population level to reduce, in fact, transmission? And there are some very good examples. The best example, I think, and it's not just because I lived in Sydney for a very long time and love that city, but I think Sydney, Australia is a good example of how very quick, good scale-up of HIV and PrEP, HIV services and PrEP has led to a very quick reduction in incidence in that country, in that state. There are also some examples that I'll be showing you from the UK. I haven't got examples from France, but that would be another model, so I'd be happy to hear about that. But essentially, there are very, very few countries or very few areas where we can say that PrEP is being effective. Why? Because we're probably not measuring it properly and we don't have the data. And as an epidemiologist, I'm pleading with everybody to try and really push for that evidence as we scale up PrEP, because we won't know whether it's working, and that's really very crucial. And it goes hand in hand with so many of the other issues, such as testing. In the US, it's a good example, and I'll show you that. The US is a good example in that because there are so many states and so many differences of delivering PrEP. You have basically low-income country versus high-income country all in one. And you can see there what's happening across. Now, Temel showed this. Ooh, I wonder if that's the beginning of my slides going wrong. Some countries are seeing a downturn in new diagnoses. Now, it's complicated to use new diagnoses, but it's still a very important marker. And we know that that could be just because all the countries have stopped testing their gay men, for instance. Now, clearly, we know that's not the case, but unless you've got context around that data, you can conclude anything you want. We're hoping that most of those countries are because they're reducing their transmission and therefore their new diagnosis is reducing. But it could be lots of other issues. And in fact, if I go back to the slide that Temel showed also around how much PrEP is being used, and I put an asterisk, they were the countries where they actually showed a decline. And some of those countries were not even present. So the scale-up of PrEP in relation to the downturn in new diagnoses isn't really very relational at this stage when we're looking at it. That's because it's complex, okay? And the testing issue is as much about having, the PrEP issue is as much about having testing available. And as you can see from Temel's slide, that was very, very hit and miss. And that's because it is and should be a combination prevention package, not just testing, not just PrEP. It comes together. So I'm going to quickly go through what I think are some, and they're not exhaustive at all, but why PrEP may or may not have an impact at a population level. And I'll start on individual level, and we've talked about this already. If individuals who need it don't take it, then we have a problem. So there's a huge issue here about ensuring that people are aware, access, affordability, and tolerability of those drugs. As Temel showed again in the EMIS and other data sets, we're far from that. The need for at least 500,000 men and unknown numbers of other groups needing PrEP in the EU alone really shows that we're far away from awareness and accessibility. There's also the individual factor of getting monitored. Now, a lot of people are using PrEP informally. There is a worry that these individuals are not able to test frequently for HIV and STIs or have other baseline tests such as renal tests, and that's an issue. And also, when they get, and if they do get HIV, and hopefully they don't, that there is accessible treatment and people can be quickly put on therapy. At the system level, there is, of course, and I think this conference it's important to discuss, are the issues, the political and the legal context in which people are working is so different. And you can have a very nice formulation of what PrEP implementation looks like, but if you don't have the will and political will, and we've heard that this is not the case in many places, then PrEP will not have the impact it needs. I'm really saying things that are very obvious to everybody, but we need them out on the table so we can discuss each. It's really also important that we have good scale-up of testing services, and where that is done, we need to be quite creative. In the UK, that's been done traditionally in STI clinics. We're doing a lot more of that on the internet, and that might be the future for a lot of people across the country as well, of where people get tested, across the region. People factors are also very important. And here what I mean about people, it's population level. When you start introducing PrEP in a context where incidence is extremely high, the impact may be much more prominent than if the incidence has already dropped. So the context and the prevalence and incidence of that country is going to make, obviously, is the context for the impact of PrEP. I've put here context around ownership of the community, because also it is the right people taking the tablets when they need it, and having access to those tablets changes over a lifetime of an individual. Some people will benefit from PrEP in their lives today and may not. And, we talk about all sorts of... what becomes extremely important in assessing whether or not PrEP is working is this issue of what is the size of the risk population and what proportion of the risk population at most risk, who would most benefit, are taking PrEP. And that can very much change both the cost, the implementation, but also whether or not it has an impact on overall incidence. Because it's not only the individuals, obviously, who are taking it, but how by taking PrEP, they are also reducing onward transmissions that would have occurred in the wider population. And a plea again for surveillance systems that, again, are not in place in many countries, where we need good surveillance systems to understand both PrEP uptake and awareness, but also testing and treatment data. So the impact of PrEP at the Fast Track City, Gus gave me this slide, was actually looked at by a Gilead group. And this is a very fast look at the levels of PrEP use versus incidence, and a correlation there showing that in the states where PrEP has been scaled up, incidence looks like it's dropping. But it's a fairly simple model, but it's a good in the right direction, if you like. At Fast Track Cities, there was also another model looking at 6 cities across the US, and this is where I was saying to you, in those cities, and it's hard to read, and obviously these slides will be made available, so that's why I've put quite a lot of slides here. You can see that the prevalence of those cities, there, yes. The prevalence in those cities ranges anywhere between 1%, which is basically a generalized epidemic in Miami, versus still very high rates of HIV across these cities. What they did is looked at every intervention as part of the combination prevention to see what were the right combinations. Should we do more of PrEP? Should we do less of PrEP? Do we know more of tasks, more of testing? So it's quite a bit asked, and they had, I think, something like 100,000 inputs in the model. So, we're talking a very large scale. And what they looked at are some of the interventions mentioned here, around protecting, diagnosing, and treating individuals. And there were over 16 of these types of intervention, put them all in the model to look at whether it has an impact on incidence, and if they were brought to scale, they would have seen that it should have reduced incidence, but at this stage, and where they were at, these programs were not going to reach any of the targets by 2030. And here, and this is just a colourful, here it shows the, if you like, the proportions of each of these interventions that would be required. And the reason I do this is because this is the PrEP area. As you can see here, they were not saying you should do PrEP 30% somewhere. And a lot of people have said, how much will PrEP reduce incidence? Is it 30% of the whole thing? Is it 10%? Is it 20%? All I want to show with this slide is that it totally varies on context, on the epidemiology, on so many factors that you can't just say PrEP is going to do X and will reduce incidence by 30%. Okay, that's just important. Okay, so they concluded, however, that all of these things were wonderful, except that if they were not going to properly be able to provide these interventions to their higher risk populations, and in particular the most vulnerable populations, which in this case are Black and Hispanic MSM, they were not going to reduce their incidence in any of these cities to the targets appropriate. So I wanted to show you quickly New South Wales, which has probably been the well-documented success story of PrEP. What's important with PrEP in this area is that they start already with a very strong health system which has been already scaled up for testing gay men. And they have probably 90% of gay men, most at risk, testing every year anyway in this city. And they scaled that up very, very quickly, again with PrEP. And they saw a very rapid downturn as PrEP use, as you can see the lines, was rolled out. There's a good paper that you can read about it, which shows all of the data. What's important there is our results support the population level effect of PrEP. In less than 2 years of commencing PrEP rollout, it's had the impact that it was required. It worked because it was rapid, targeted, high coverage rollout, and that reduced incidence. It's also coupled with the fact that people who seroconvert are put on treatment very quickly in that country. So this is a success story. Oop, doing the wrong thing. What's important, I think, with all of these effectiveness type studies is that they start out with what they think is the high-risk population. And this is not easy to do. And we've said a lot of people know they're high risk, but there are guidelines, and it might not suit those guidelines. And at the beginning, they thought, from looking at the definition of high risk they use, they would probably have about 3,000 to 4,000 people on PrEP. Actually, within 12 months, they had more than 8,000, and then it moved up to 12,000. This has been the same case in the UK, where we thought we probably need about 10,000. Well, we're saying probably 25,000 is a high risk in the US, etc., etc. What's happening is that we're really underestimating the number of people who need it. That is really important because we will need to keep changing what is required, and that will obviously impact on our modelling work of cost effectiveness, etc. But what's also important is that people will stop and come back to PrEP. So over time, I think these numbers will change because the populations using PrEP will become different, and that will have a different impact on our services. San Francisco is another really good example with very good data where over time PrEP has had a really important effect. And there's very good data with reports, so just highlight those. Those reports are available. Again, what's been key in that city is that it's not just about PrEP on its own, it's about time to treatment and very quick time to treatment if you're diagnosed. So again, there's some really good data there from San Francisco. And finally, a very quick word on London. We're getting there with London. What's been interesting here is that initially in London, We actually had a downturn probably before a large scale-up of PrEP because we had such a strong test and treat change in the last few years. And a lot of that was down to Dean Street. And we've said it was all about PrEP, but look at the testing rates that went up in Dean Street. Phenomenally testing up, up, up. And new diagnoses went up before they went down. And testing time to treatment dramatically, as Neko talked about yesterday, also reduced. So I think this slide is as much about the success of combination prevention in Dean Street as it is about PrEP implementation. And I'm going to leave it there because I've got so much to say. Back to my take-home messages. Thank you very, very much.
We have time for only one question.
I had a lot of acknowledgements. Can I go back to where the questions are on? Because I think people need to be acknowledged. That's really important.
Okay. There is one question. Valerie?
Yes.
Wait.
Thank you, Valerie. You say that the decline that you've seen in London cannot be really attributed to PrEP.
On its own.
On its own. And we're seeing the same downward trend in many other settings, and we also say that it cannot be attributed to PrEP on its own. But we do not record PrEP use very well, do we? How many of these men were using PrEP? And we did not have those data, because when I see the declines in Spain for the last 2 years, there's huge also reporting delay, but some possibilities that decline we're seeing is due to informal PrEP use that we're not recording well. So I share completely your interpretation and your views, but I worry that with lack of data, it's hard to be conclusive, really.
Sure. So I'm not conclusive saying PrEP wasn't part of the equation.
Yeah.
I'm really very strongly pushing the combination prevention. In the UK, even when PrEP was being used informally and Dean Street were using it before you were formally, if you like, it was part of a program of repeat testing, making sure people were coming in every 3 months. So we've got a very different culture around testing, around sexual health, and that, I think, is the strength of it. Yes, I think there is lots of underreporting of informal PrEP, and it's part of the picture. I don't think, also, we will probably, when we've said downturn, that doesn't mean it was the end. We could have had a downturn for a while and might have plateaued off. So PrEP may be, and is absolutely fundamentally part of the solution of getting down to elimination. I keep my hand up. I think if we can keep PrEP on the agenda, available to high-risk individuals at the time that they're high risk, as part of the combination prevention, and we have good testing facilities, and we're putting people on treatment, we can, yes we can, get rid of HIV, eliminate HIV in this lifetime. There is no doubt about that, we can.
Yeah.
But will we?
Thank you very much.
Thank you, Valerie.